Happy to be with you, talking a little bit about, sort of at a zoomed out 30,000-foot view, the relationship between the use of diabetes medications, and in particular medication adherence, and the quality of care. And so I'm going to talk a little bit about some of the policy and practice trends that we see happening right now, some of them starting in Washington, but rapidly emanating out into the healthcare system. And Dana just reminded me not to use all of my time, so I'll move as quickly as I can. So no surprises here. Non-adherence to diabetes medicines is a substantial contributor to what many people think is about a $300 billion a year problem. IMS Institute came out yesterday with a new report on this, putting it at about $100 billion for only 6 therapy areas, but diabetes was one of them. And whether it's 100 billion or 300 billion, it's a really big number and it's a really high priority. Interestingly, if you look at this chart, which is some research we published in the Journal of Managed Care Pharmacy a few years ago, oral diabetes meds had the best rate of adherence over time among these 6 chronic therapy areas, which include blood pressure, cholesterol, osteoporosis, glaucoma, and overactive bladder medications, all of which, by the way, are the focus of quality measures today. And of course, this point I think has been driven home in a number of presentations today, but there's pretty good evidence that links or connects the dots between adherence to diabetes medications and clinical outcomes and excess costs. This is some work by Michael Ho, who I think does a nice job of illustrating those excess costs. It's going to give me motion sickness to turn around and try and look up on this giant screen, but I'll use the pointer. All-cause hospitalization, rates of all-cause hospitalization adjusted for a variety of different clinical and demographic factors. Look at these excess risks of all-cause hospitalization for patients. These are all diabetic patients, but non-adherent to their antihypertensive medications, their statins, or their oral hypoglycemics. And then here, all-cause mortality, also substantial increases in risk. So the good news is, that's more scary news, on top of psoriasis, scary news about the increasing prevalence of the condition and now the increasing rate of non-adherence and the clinical consequences of it. Here's the good news. The good news is today we stand at an unprecedented point in history to make big progress on this problem. And that's because of a variety of macro trends that are all taking hold in the healthcare system at the exact same time. So I want to walk through a few of these examples and talk about what we see happening today from the front lines where I work in the private sector trying to help organizations improve. So the first is there's obviously a growing amount of evidence linking adherence to clinical outcomes and costs. And I just showed you an example of some research by Michael Ho, and Darius is doing excellent modeling work. There's some very persuasive work being done by the Congressional Budget Office and MedPAC trying to look at the links between adherence and these outcomes. And so it's taking hold. And what does that evidence do? Well, that evidence works its way into the development of quality measures. And so that's the second step here. Consensus-based measures of quality medication use are now being adopted in a number of key therapy areas, diabetes chief among them. So the organizations that develop these measures include the National Commission on Quality Assurance, NCQA, the Pharmacy Quality Alliance, which comes up with the adherence measures, and the National Quality Forum, NQF, is our national consensus body that endorses such measures once they get graduated by these measure developers. And the NQF graduated their first set of adherence-related quality measures in 2009, and they were very rapidly taken up for performance-based payment, which is our third point here. So what we're seeing now are now that we have adopted consensus-based measures of what adherence ought to be in these therapy areas, it's now being adopted for performance-based payment, and that includes changing benefit design. So think of systems for performance-based payment that include the STAR ratings, which is Medicare's yardstick for evaluating Medicare Advantage plan performance or Medicare Part D plan performance. The HEDIS measures, which are used broadly to evaluate the performance of payers that sell commercial lines of business and Medicaid. The Accountable Care Organization quality measures consist of 30 measures, and by my count, about 20 of those can be positively impacted by better use of prescription drugs. And then there's meaningful use, the incentives for physicians and hospitals to use electronic medical records. There are a set of measures that the bonus payments those entities receive depend on, and those measures are increasingly focused on the better use of prescription drugs. Add to that trend the falling cost of most primary care therapies, and you have lessening payer concern about the cost of improving medication adherence. 5 years ago, this would have been a big, difficult story to argue because Lipitor was $4 a day, and now it's pennies a day. And as that's happened to a number of our biggest, most widely used medications, payers don't have to worry as much about whether they'll see those medical cost offsets that are larger than the cost of improving medication use. And finally, the other encouraging thing here is that there's growing evidence that we actually know how to improve adherence. And as frustrated as many of us are that we're not improving adherence widely, the truth is that it's not because we don't know how. And I'll talk a little bit more about what that means in just a moment. But if you put all those macro trends together, what you see is a growing number of quality measures, the attachment of dollars to those quality measures for a variety of stakeholders in the system, and the most important point is incentives are now aligned in a way they haven't been. You know, many people used to think of this as pharma's problem or as patient's problem, but now it's payer's problem and it's provider's problem. And so we all share responsibility for making this better. Just a quick overview and a timeline for some of those trends that I just discussed. You can see here, some of you Hippocratic scholars might recall that Hippocrates was the first to report on this problem. But over the number of years, 40,000 articles on the topic being published, here are the quality measures being adopted, and then suddenly Medicare became the first to pay for improvements in medication adherence, particularly in diabetes, blood pressure, and cholesterol. I'm going to go into one more slide of detail on these Medicare measures because these are really driving hair on fire levels of panic in the payer community today. The star ratings are the yardstick, as I said, that are used to evaluate Medicare Advantage plan performance and Medicare Part D plan performance. About a quarter of all Medicare beneficiaries are in a Medicare Advantage, that is a private sector Medicare plan. Those 53 measures that comprise the star ratings consist of 11 that are triple weighted because Medicare considers them to be measures of outcome, not just measures of process of care. So these outcome measures get 3 times as much weight in the star ratings, and collectively the medication adherence measures account for about 30% of a Part D plan's overall star rating and 25% of a Medicare Advantage plan's overall star rating. And if you look at all 11 of those triple weighted outcome measures, this is some analysis we've done of publicly available Medicare data, on average, of those 11 measures, 9 of them are dragging down the overall star rating for those plans. And so you can see that mental health is over here on the far left, generally on average of 1 star, more than 1 star lower than a plan's overall average star rating. And star ratings, 1 star jumps in star ratings mean very substantial bonuses to these plans. So this is a huge problem. But you can look at readmissions. Look, here's diabetes treatment. Adherence to hypertension meds, adherence to oral anti-diabetic meds, and blood sugar control. 3 of the 11 triple-weighted outcome measures evaluate the quality of drug therapy for diabetes patients in the Medicare system. So the hair isn't just on fire in general about adherence. The hair is on fire about better control of diabetes through better medication use. So how are we seeing plans respond to these incentives? So my business provides tools to the plans, the PBMs, the pharmacy chains that are trying to improve. And we use big data and analytics to do that. But what our customers are doing is shown here. They are multiplying the amount of money that they spend on drug therapy management programs from the years 2011, when these programs were first introduced, these incentives were first introduced, to the current year. Like not just marginal 20, 30% improvements in those budgets, multiplying those budgets. Because the opportunity for a plan that wins at this game is to double their profit margin on their Medicare line of business. So this is a big incentive. They're establishing new relationships with MTM and other intervention providers, vendors that can do this for them. They're hiring new clinical staff to support educational programs, both to their members and to their providers. And get this, they're creating increasingly performance-defined preferred provider networks, not just on the physician and hospital side, but also on the pharmacy side to drive further improvement. Now, the early effects of this policy are still being measured. This is old data, but 2010 is a benchmark year. These are the national rates of adherence in the Medicare program to 3 categories of drugs. Diabetes is the blue line here, and this is just oral diabetes meds. So you can see a marginal increase from 2010 to 2011, but that's because these incentives were just introduced in the 4th quarter of 2011. Very little opportunity for improvement in 2011. The 2012 calendar year will be the first opportunity to see the full impact of this policy and what plans have done in response to it. And although Medicare has not publicly released that data, our clients make that data available to us, and I can tell you it's going like this. It's a very substantial improvement on a national level in the Medicare program. So these incentives are working. There's a lot of exciting innovation going on, and I won't go into detail on these, but any payer that you all talk to will tell you that they want help implementing and evaluating strategies for improving medication use among their diabetic patients. These are examples of some of the common things going on in the area. I won't spend time on them today, but this is an area that's ripe for further research and practical implementation. Another note on these measures is that currently CMS, I think this was pointed out in a presentation earlier today, but I want to drive this point home. CMS diabetes quality improvement measures for drug therapies do not include insulin. And that's because there's not a lot of confidence that we can measure adherence to insulin therapy using claims data, which is how Medicare measures adherence. And so there's a strong need for some consensus-based measures of how people using injectable diabetes treatments can measure that and can use and adopt that as a quality measure, because many other forms of diabetes medication use are measured, but not that. So where are we headed from here? And this is really the last slide. A couple of comments on future directions in both policy and practice. I think that we can expect to see a cycle that looks sort of like this diagram over the next few years, which is an attempt to improve diabetes outcomes through, first of all, much more active phases of measure development. Consensus-based quality measures, especially in the area of medication use and adherence, will continue. I wouldn't be surprised if we saw some attempts at measuring injectable diabetes treatment adherence over time. But those measures by themselves don't cause anyone to do anything differently. The next thing is incentives, and everything we hear coming from the Medicare program and the Medicaid program is about more and more value-based purchasing and payment for performance. So I expect to see more of these incentives put in place, and wherever they start, those incentives roll downhill, particularly toward providers like pharmacies, physicians, and hospitals. And then comes the important piece, which is the liberation of data to enable these organizations to actually manage this. And they can't manage it if they have to worry about everybody in the population. And although I'm not talking about it in detail today, this is the field that we and many others are in, which is trying to help these organizations with tools to process that information, stratify patients based on their risk, and help them make good decisions about the most cost-effective way to manage each patient. Once we know what works, and by the way, as I said, we still need help measuring what works and identifying best practices, those best practices will drive continued focus on improvement, and the process repeats. But here's the practice side of this. If that's what policymakers are going to continue to drive in the future, on the right-hand side, this is what the healthcare organizations of today have to figure out how to do. When it comes down to managing adherence to diabetes treatments, they need a plan, which includes knowing what their goal is, how much adherence is enough, what interventions they have to deploy, what those interventions cost, what kind of constraints are on those interventions, and what they can reasonably expect to achieve from one year to the next. Once that plan is in place, our system provides them with tools like predictive analytics, decision analytics to identify who's at risk and then what intervention is most cost effective. And then once that's deployed, a systematic way of learning what's working and what's not. Not only on average, but within specific subgroups of at-risk patients. So that we can facilitate what we really want out of the healthcare system, which is this arc of improvement over time. Consistently targeting the patients at risk, giving them the most cost-effective interventions, learning what works, and then rinsing and repeating the process. So I'll stop there and look forward to a good discussion. Thanks everyone for your attention.